So I am standing between you and lunch. So we are going to learn, and we are going to learn quickly. And ultimately with this presentation today, we're going to cover a lot of different topics. And the idea is really to kind of whet your appetite, to encourage you to go learn more, to encourage you to increase your study and your understanding. And at the very end of the presentation, because QR codes are the name of the game today, there's a QR code at the end that is all of my sources. Everything that I used for this presentation is in that QR code with hyperlinks so that you can find it, you can study it, you can look at it. And I will tell you that one of the biggest influences on this presentation as far as the opioid epidemic and the opioid crisis is a book called The Empire of Pain. There's a link in my sources for that, but I highly recommend that book if you want to understand just the influence of big pharma and aggressive marketing and the Sackler family and OxyContin and just the damage that that drug did to our society. Your mind will be blown. But all of that to say, as we get started today, check out that book. Like I said, it's in my links. But anyway, all right. So this is a little bit about me. I have been a nurse for 22 years. In that top picture, you can see me and my then fiance. We got married 5 days later. But I've been in nursing for 22 years. I've been in the OR for 13. And I've done a lot of different things because my husband was in the Navy. But one of the things that has influenced my passion for pain management and my passion for controlling and understanding and appreciating a patient's pain is the time I spent in pain management. Pain management was what I did for about 4 years before I went into the operating room. And a very eye-opening experience for sure. I'm also the founder of The Circulating Life and the co-founder and chief nursing officer of First Case Media. In that middle picture, you can see my co-host of the podcast. Her name is Chris Blevin. She's a surgical tech. So we can bring the voice of both the surgical tech and the OR nurse to the airwaves when we talk about different topics, which I think is very appropriate that everyone gets representation when we are speaking on different things. And then I also still work in the OR. I'm an OR circulator at Vaughn Regional Medical Center in Selma, Alabama. If you are familiar with your civil rights history, then you will know where Selma, Alabama is. If not, we are a little bitty town about an hour west of Montgomery, Alabama. Not very big town at all. But I also, in this bottom picture here, you will see there's anesthesia providers, scrub tech, RNFA, 2 nurses. This is a group of people that I was in Honduras with. And these people and that trip to Honduras that I went to last December was another one of the catalysts and motivators for this presentation because I was working with opioid sparing surgeons. I got to see up close, not just in the OR like we always see every day, right? We see them in the OR, but we don't see them necessarily in pre-op, what they're doing ahead of time. We don't see them in PACU, and we don't see them going home typically because we're all very stuck in our area. In Honduras, that wasn't the case. We were doing it all. And so I got to really see the benefits that these patients were experiencing from their regional blocks, from the different ways that we were managing them without opioids. And it was very eye-opening. And then one more little thing just about me, because these are the people who support me and these are the reasons I do what I do and the people who make it possible. My youngest is 14, he's 6'1". If you can believe a 14-year-old is 6'1", he's enormous. My middle, Nathan, is 21. He's an electrical engineer and Army ROTC cadet at Auburn University. And my daughter, Catherine, is a senior this year, and I'm going on to study ballet after school. But anyway, that's my crew, and I live in Alabama, beautiful Gulf Shores, Alabama in that background because we love our beaches and love the coast. But that is just a little bit about me and the people who are behind me and support me with everything that I do. But as we think about our topic today, these are our objectives. If you're all the way in the back, it's not going to hurt my feelings if you can't see them, because I'm sure you can't, because I sat back there and I know you can't. But if you want to move forward so you can see better, go ahead, it's fine. But ultimately, we are going to discuss the intersection of surgical care and the opioid epidemic. We're going to look at its impact on our patient outcomes and our healthcare systems. We're going to look at the advantages of integrating ERAS pathways into our perioperative care. And we're going to look at some complementary therapies that are accessible to patients to manage operative and post-operative pain and also understand their effectiveness, those potential benefits that these complementary therapies can provide to our traditional surgical model. So the opioid epidemic, let me ask you a question. How many of you, when you were in nursing school, were taught that if a patient is legitimately in pain, they cannot become addicted to prescription pain medicine? Anybody? Anybody taught that? Yeah, so was I, okay? I was taught from day one that if a patient is legitimately in pain, they They will not become addicted because they really are hurting. And that's not true. We now know, but that is what a lot of us were taught. That is what our healthcare providers, our surgeons, our doctors were taught in medical school. As long as it's prescribed by a doctor, as long as they are really in pain, they're not going to become addicted. But we know better now. And so today what we're going to talk about and look at, is the opioid epidemic. And we're going to today remember that the lens, I guess, of this presentation for the purposes of today, we're looking at the intersection of surgery and the opioid crisis. Obviously, the opioid crisis is going to refer to a lot more than just addiction and death from prescription opioids, but all of the opioid crisis is still rooted in the same history. So if we look here at the history and where did this all start, what happened, ultimately the opioid crisis is widely considered to have its roots in the mid to late 1990s, starting with the FDA approval of OxyContin in 1995, and then the subsequent aggressive marketing campaigns and tactics by pharmaceutical companies, particularly Purdue Pharma. They were influencing physician behavior. The US healthcare system began to greatly increase their prescribing of opioid painkillers. OxyContin was considered to be this breakthrough in pain medicine. It was sold to doctors as this drug that was non-addictive, that was minimally addictive at best. If it was prescribed by a doctor, patients could not get addicted to OxyContin. And around the same time, in 1996, the American Pain Society coined this term, the fifth vital sign. We're familiar with this, right? We have the fifth vital sign of pain. And it's in the context of quality of care, which is good, right? Pain should be measured, pain should be treated. And it was quickly picked up and it was incorporated into several different practice guidelines. You had the Veterans Health Administration's Patient Care Toolkit. We had the Joint Commission, the Agency for Healthcare Research and Quality, and other specialty groups were all picking up this language. And it was well-intentioned and very good that we should be treating pain. We should not ignore a patient's pain. But side effect of that, this led to measuring the treatment of pain as an outcome. And so patient pain scores and patient satisfaction with their pain management and the treatment they received became routine elements of clinical evaluation in doctors' offices, clinics, hospitals across the country. And I don't know how many of you are familiar with that third term there, HCAHPS, but a lot of us have heard about HCAHPS scoring, right? If you're not familiar with it, the HCAHPS is a 32-question survey from CMS that measures a patient's perception of their hospital stay. So it is all based on what the patient feels like they experienced or what they think about their care that they received. So the survey is given to patients who receive medical, surgical, maternity care services, and they get it like 48 hours, maybe to 6 weeks after they were in the hospital setting. But it focuses on 9 different topics, and one of those topics is pain management. So if you put it all together, what we had in the late 90s was a perfect storm. We had the false information about the addictive nature of OxyContin. We had a very well-intended effort to prioritize the treatment and management of pain from the American Pain Society. And then we had the inclusion of pain management to HCAHPS surveys. And remember, what do those HCAHPS surveys ultimately affect? Our money, right? And like they said last night, money makes the world go round, right? So we wanted to have really good surveys. We needed to have really good scores. Why? If the doctors didn't get good scores, if the hospitals didn't get good scores, they could be penalized. They might not get refunded for procedures. They might not get the money they needed. So what was our goal? Make sure they don't hurt at all. Don't let the patients hurt, because if they hurt, they're going to give us a bad score. And if they give us a bad score, then we're not going to get any money, right? And so now the goal was to make sure our scores were good. And one of the ways we could do that was to make sure the patients did not hurt at all. And since they thought they had these medicines that were non-addictive, give them the medicines, give them all the prescriptions so that they don't hurt, so they score as well. And you could see, as a surgeon we're going to look at here later in the presentation, he basically said that surgery became a gateway to addiction because we were over-medicating, making sure they weren't hurting, making sure our scorings were good, and our patients were ending up addicted in the process. So that's where it started. This is going to be kind of hard to see for you guys in the back, but I know that you'll get access to the slides later so you can look at them a little closer. But That's where it started in the mid to late 1990s. And what has happened though since is really the question, right? We know where we were. What has happened in the years since then? For more than a decade after OxyContin was released, the steadily increasing rate of overdose deaths involving prescription opioids continued, but people weren't really paying attention to it. Any report to the contrary that said that OxyContin was addictive, or maybe the root cause of the crisis, of the opioid addiction crisis, was shut down and quickly silenced by Purdue Pharma. They would not hear anything to the contrary that said that their drug might be addictive or might be causing a problem. Finally, in 2011, the CDC declared deaths from prescription painkillers an epidemic, and in the years that followed, the US healthcare system and public health systems took steps to rein in that excessive prescribing. They had new guidelines that were aimed at reducing some risky prescribing behaviors. A lot of states were implementing legal restrictions on prescribing and how you could get prescriptions, or the different rules for all of that. And then you also had well-meaning attempts by your healthcare providers to voluntarily be more cautious in prescribing opioid pain medicine. And there was some degree of success, but overdose death rates never really declined in a large or appreciable way. And around the same time that prescription opioid deaths peaked, data on drug overdose deaths show that the opioid crisis made a distinct shift. Because what happened? What do you think happened? If you couldn't get your prescription opioid you're already addicted to, what did you do? You went to the street, right? So what did we have? We had heroin deaths that began to surge in 2011. Okay, methamphetamine deaths were starting to rise. Then in 2014, we started seeing deaths rising from fentanyl, cocaine in 2016, 2020, they're all accelerating, fentanyl, methamphetamines, cocaine, et cetera. So people who had become dependent, had gotten addicted through OxyContin, maybe through surgery, through seeing a surgeon, through having healthcare, they were given prescriptions to pain medication and now they could not get them, but they were now addicted, turned to other methods so that they could still manage their addiction, even manage the pain that they felt like they were having. So with all of that in mind and seeing what this looks like, where are we currently? Okay. What are the statistics surrounding the opioid epidemic as a whole, but more specifically related to addiction to prescription pain medicine? And according to the CDC, all of these statistics are from the CDC. You can find statistics all over the place. I opted to go with the CDC statistics just for consistency throughout, just because a lot of people, a lot of different websites have a lot of different information. But drug overdoses, according to the CDC, are one of the leading causes of injury death in adults and have risen over the past several decades in the US. In fact, the number of people who died from a drug overdose in 2021 was 6 times the number in 1999. That is mind-blowing. From 1999 to 2021, nearly 645,000 people in the US have died from an overdose involving any opioid, including prescription and illicit drugs. Prescription opioids by themselves are implicated in 32% of opioid overdose deaths annually. That is a huge number. In 2021, 220 people died each day from an opioid overdose. And then the economic toll, because we look at how all of this, yes, our patients are affected, yes, our patients are dying, our families are dealing with the struggle of addiction, and what is that economic toll on our healthcare system, on our legal system, on lost productivity? The average has a price tag of $78.5 billion each year across healthcare and legal and lost productivity. Those are huge numbers, and they have not been declining. We've seen some shifts, but that's a big number to have to deal with, and that many people dead is very sad and very heartbreaking. And there are so many different ways and things that we can do to change that when it comes to patients being exposed to surgery and having healthcare, and then how are we optimizing them and taking care of them and treating their pain, but not setting them up for potential risk for addiction. So there are a couple of other numbers that I want you to hear, and I don't want you to hear them from me. This is Dr. Scott Sigmund. He is a opioid sparing surgeon, fascinating guy. I worked with him in Honduras. And so I want you to hear what he said, if I can get it to play. He did a TED Talk that I also gave you the link for in the source sheet, but I want you to hear what he says.
So the year was 2012, and the opioid crisis had become personal. 5 young student athletes in my local community learned on various surgical procedures. 6 months later, they were dead of opioid overdoses. I know this because my wife is a local health. She had to prepare the flowers for this devastating family. All I knew is that I was an orthopedic surgeon doing what I was been taught. From day one in my training, I was told, what you do hurts. You use saws, you use hammers. You're going to hurt people. You need to make sure that their pain is under control. So that's exactly what we did. The problem was something wasn't right. Not only was I an orthopedic surgeon, but I had become a pain management specialist. What does that mean? First and foremost, they had told me, you're going to use opioids. You know why? Because they're inexpensive and they're minimally addictive. How far from the truth was that? What I was doing, I was seeing patients, writing refills for opioids, weaning patients off opioids prescriptions as well. I had belligerent patients that were threatening to take to the Board of Registration in Medicine because I was neglecting their pain. Something was wrong. Why were we doing this? How did this happen? There must have been great science, research, studies that show that these new opioids were going to be less addictive.
Hold on, we're going to skip forward because we don't have time to watch his entire thing, although I highly recommend that you go back and watch it. But here are the numbers that I want you to hear now that you've heard a little bit of his backstory.
Pain became the issue of our medical generation. We were confused, we weren't sure what was happening, but one thing for sure is that opioids were much more addictive than we were told. So I have 3 numbers here, 6, 13, and 30. In 2017, the Centers for Disease Control published an article about opioid prescribing. They took a look at thousands of patients that had been prescribed opioids. And there were 3 inflection points. The first was if you wrote a 24-hour prescription of opioids for patients, 6 out of 100 had a chance of being on opioids with 1 year after a single day prescription of 24 hours. If you gave them a 10-day supply of opioids, 13 out of 100 had a chance of still being on opioids in 1 year. If you wrote a 1-month prescription, which was very common at that time, literally 1/3 of those patients could still be on opioids in 1 year.
That's crazy, right? And it's not something we realize, and it's not something I think in the OR that we think about because we see our patients, they come in, they go out, and we don't see them again. But our surgeons and clinic staff are seeing them on follow-up and later and later, and that rate of addiction is terrifying and very sobering to think about what our patients were experiencing and what was going on. But I think it helps to hear it from a surgeon who was at the forefront of it and what influenced his push really to focus more on opioid sparing surgeries. But it also, hearing his numbers and thinking about how perhaps surgery could have become a gateway for addiction, it really helps us see something bigger about the way we had been handling and providing surgical care. Because we were treating our patients post-operatively for their pain and for conditions that they were experiencing that were exacerbated or caused by their surgical experience. So in a word, we were reactive. We were taking care of our patients from a reactive point of view. You can think about it. What's the biggest instruction that we give our patients before they're going to have surgery? What do we tell everybody? What do we tell them before surgery? Nothing to eat or drink after midnight, right? So we get them in this prolonged fasting time. It results in dehydration. Then because they're dehydrated, we give them a ton of fluids intraoperatively, but we're also giving them opioids, right? So our patients in the traditional model, they're going to have surgery. We have them fasting, but then because they're fasting, we give them extra fluids and now they have a fluid overload. Well, then because during the surgery, we're giving them a lot of opioids, or after the surgery, we're treating them with opioids, but that can lead to them having some oversedation. And then also in that same time frame, we were instructing our patients to lay in bed, to rest. We weren't doing early ambulation and other things that we know now are so much more helpful. And we weren't getting them up and moving them quickly after surgery. But we know now that what we were doing was actually causing harm and was leading to a post-operative functional deterioration. Coming in dehydrated and fasting does not give the body an adequate carbohydrate load to prepare the body for the stress of a surgical procedure. Overloading the patient, I'm a step ahead, but we're just going to leave that slide there. It's fine. Overloading the patients with fluid, it can lead to delayed wound healing and cardiopulmonary complications and electrolyte imbalances. And then high levels of opioids led to nausea, vomiting, decreased bowel motility, and constipation, which was further exacerbated by their decreased mobility, right? So, and then decreased mobility has its own array of complications like blood clots, muscle atrophy, skin breakdown, and all of these factors contributed to an increased morbidity and mortality, longer lengths of stay, and increased risk of opioid dependency or addiction. All of these things that our patients would experience with our traditional model because we were not optimizing their care for surgery, we were not thinking about them holistically, but we were basically reactively treating all of the problems that we caused when we were having them come in and doing things in a more traditional model. So if we take all of that and all of that information, okay, thinking about what we know about the opioid crisis and that patients coming in to have surgery were being predisposed or being more exposed to opioids so that they had an increased risk of addiction, right? And recognizing that surgery was becoming that inadvertent gateway to addiction. Also that our approach to managing surgical patients was causing harm. It was increasing complications. What did we do about the problem that was in front of us? How did we handle that? How did we address it so that we could change surgical practices so they could be more patient-centered, that they could have a proactive approach and ensure that our patients could have their surgeries, that they could manage their pain, but also avoid unnecessary opioid exposure and complications and increased length of stay. So to answer those questions, we actually have to go back to the 90s again. It's like funny how the 90s are coming back up. We had a 90s party last night and here we are, right? So we're going back to the 90s again. And there had been developments in regional anesthesia techniques, and that led to an improvement in the ability to control pain. We also saw the wide adoption of minimally invasive laparoscopic surgical techniques, and we were experiencing a significant improvement in post-operative recovery and an earlier return of patients to their normal function from these different techniques. Also, around the same time, there were results that were published of fast track. I'm sure you've heard of fast track techniques and things. That's kind of your precursor to some of these other things that we're going to talk about, but fast track recovery techniques in patients. And one of the studies was looking at patients who were having coronary artery bypass surgery with some modified anesthesia protocols. And the goal was to reduce their extubation times. But what they found was it also led to a 21% shorter intensive care unit length of stay, a 19% reduction on hospital length of stay with comparable rates of morbidity and mortality. And then other studies on rapid recovery programs combined general and epidural anesthesia, early nutrition and mobilization, and reduced opioid use that were reporting shorter hospital stays after intestinal surgeries. And a lot of you are familiar with ERAS pathways being used in your colon, your GI surgeries and whatnot. And all of the benefits of our patients with these pathways were being seen. And so on the basis of those results, a group of European surgeons developed the concept of multidisciplinary, multitask, patient-centered, and evidence-based perioperative protocols in 2001. Their model broadened the spectrum of interventions from post-operative care, where we had been stuck in that reactive model, to the entire perioperative period, moving us to a more proactive approach with these pathways. So the creators actually became known as the Enhanced Recovery After Surgery, or ERAS study group, and their primary goals. And that's really what you want to look at here, okay? We've got multidisciplinary, multitask. So we're a collaborative approach, right? Bringing anesthesia, surgery, and nursing together to improve perioperative care. It's patient-centered. We're focusing on education, on optimization, on anticipatory guidance, patient-specific therapies and engagement, but also paying attention to our patient-reported outcomes. We want to know what our patients say about their experience, using evidence-based approaches to patient care that can be applied throughout the whole spectrum, before, during, and after, but that goal is the most important. Minimize pain and risk during surgery and support healing by reducing the body's stress response to the operation. How do we do that? How do we reduce the body's stress response caused by the operation so that we can optimize our patients, control their pain, and get them back to their life as quickly as possible? That's what we want to do, right? So also, as if all that stuff isn't cool enough, because that's what ERAS pathways do, they have also been gaining recognition for their value in the opioid epidemic, because ERAS pathways and protocols minimize the need for opioid prescriptions in post-surgical patients. So if we look at their benefits and other things that we're going to talk about, once again, another hard to read slide if you're in the back, but there are the ways that we are treating our patients in with our ERAS pathways. There's things we can do preoperatively, things we can do intraoperatively, things we can do postoperatively to optimize and treat our patients. But when we look here at the benefits of implementing different ERAS pathways and protocols with our surgical patients, they have been shown to reduce costs and improve outcomes in nearly all surgical specialties, including shortening length of stay by 30% to 50%, with a similar reduction in complications and decreased readmissions. Compared with traditional care models, enhanced recovery pathways have resulted in a cost savings of $6,900 to $7,109 per patient. And the evidence-based approach to standardizing care of a surgical patient with best practices often includes regional anesthesia techniques, which reduce surgically induced stress, inflammation, and complications. They improve post-operative pain control, and they accelerate recovery. And we also are including early ambulation, which is getting patients up and moving and back to their normal functioning in life as soon as possible. Also, by including regional anesthesia techniques in our ERAS pathways, we're seeing a decrease in post-operative pain and opioid consumption. We're also experiencing a rise in opioid-sparing surgeries, like the surgeon that we just saw, Dr. Sigmund, in opioid-sparing surgeries, and also in complementary strategies that are enabling our patients to be discharged after surgery, sometimes without a single prescription for opioid pain medicine. There's another surgeon that I interviewed as well, Dr. Michael Redler, who practices here in Connecticut, and he makes a huge point when he interviews his patients or talks to his patients ahead of time. They really focus on education, guiding that patient, a lot of anticipatory guidance. Yes, you're having surgery, it's gonna be uncomfortable. Like, the expectation that I'm gonna have surgery and nothing's gonna hurt at all is not realistic. But they focus on this idea of discomfort. There will be discomfort, but we're not going to let you, we're not going to let you suffer and be in miserable pain. But how are we going to control your pain and still not use opioids? And they are big advocates of these blocks that we're going to talk about, and implementing different pain blocks to control a patient's pain, using like your gabapentin and your Robaxin and other things that are going to manage muscle pain and nerve pain. So we're still treating all of the pain, but we're not using opioids. And his patients, when I interviewed him, he said he does give them like 5 hydrocodones or something to go home with, so that if they're hurting really, really bad, they have something. But he says most of them don't even need to take it, because they've done such a good job educating them ahead of time to know what to expect so that they aren't surprised. And then their blocks do such a good job controlling the pain post-operatively. The patients have the time to recover with the block without hurting, so that they don't need it. And so it's really cool to hear what these opioid-sparing surgeons are doing. But I will get ahead of myself and talk forever if I don't shut up. So let's keep going. So when we talk about regional anesthesia, your nerve blocks, right? That's what they are. It's allowing patients to need less medication, less anesthesia, and most importantly, less opioids. It's allowing them to recover comfortably, because the nerve blocks are doing the heavy lifting for the pain relief after the surgery, especially in those first few hours. That nerve block, especially if we get that block in before the patient even has surgery, they're coming into surgery, they're numb, that nerve is not sending information and communicating with the brain, so the brain doesn't think, oh no, my body just got cut open, and freak out and start sending out all the inflammatory responses and stress response that your body would do. Because yeah, you might be asleep, but your brain still knows what's happening, right? So if we have that block in that patient before they have surgery, then they don't have that same type of response to the surgery that they would if we were just traditional model, cut them open, give them opioids, and manage their pain that way. But there are different drugs too. When we look at these regional anesthesia techniques, there's different drugs that can be used, different blocks we can do depending on the body part or whatever. But there are some drugs that are out there. One of them is called liposomal bupivacaine, but it's a long-acting, slow-release bupivacaine, right? That's the one that we were using in our blocks in Honduras. And those blocks, depending on what part of the body, depending on where you put them, patients could have 72 hours of pain relief after surgery, all from that one block. They don't go home with a catheter. They don't have anything like hanging out of them that they got to deal with a bulb or something, you know, dispensing medicine, but the block is in there. It's giving them that pain medication. And so they are numb, or, you know, it allows their body to heal basically, and the body can start healing without the risk of the pain. They can start therapy, they can start moving, they can do all these things, and that block is still in there doing all of that heavy lifting for them so they can function and get back to functioning quicker. You'll also see peripheral nerve blocks done a lot of times with ultrasound guidance, like what's going on here. This is a picture of a patient in Honduras. That's Dr. Teresa Bowling. She's also in practice here in Connecticut, and Linda was the nurse helping her. But they were doing a nerve block before we did an ACL repair. And her blocks were phenomenal, and the patients did really, really good. But she did use ultrasound. And what's cool about ultrasound guided regional anesthesia is it results in longer block durations. You get faster onset times, you get improved block success, and a reduced need for opioids for your patients. So also reducing opioid use with regional anesthesia techniques, it represents another important tool in our ERAS toolbox, in our way to optimize and holistically treat the patient so that we can control their pain without opioids. But I do orthopedics. That is my primary specialty. So I have patients who have blocks all the time because this is what I do. But I'm curious, how many of you have ever, you're going about your day, and maybe if you have a block room, the block room's gotten behind and your patient hasn't gotten your block, and so the doc's like, forget it, we're just gonna roll. You know, they can do something later and we're just gonna roll back. Is that what's best for the patient? No. It might be what's best for the surgeon and his schedule, but it's not what's best for the patient, because yeah, we can do a lot of the blocks we can do after the case, sure, and they can still at least have the recovery time for the block. But if we think about all of the benefits to the patient for that block getting in before the surgery, reducing that stress response, which is our goal with our ERAS pathways, right? We want to reduce the body's stress response to surgery. And by doing that block ahead of time, we are optimizing the pain control and the benefit of the patient through that block. So when the doc's like, no, forget it, we'll just do something later, or I'll do something else, I'm like, no, you know, I really think it would be best if the patient got their block. You know, well, now I don't always win because I don't have the authority behind me to say that, but I really like to push to make sure that if our patient is supposed to get a block, that they get that block before we roll back to the OR, to make sure they have the full benefit of that block. But blocks are just one of many, and you have a lot of different types. I put them up here on the slide. Being in the OR, we do a lot of peripheral nerve blocks, but you also see beer blocks and neuraxial anesthesia and different things like that too. Now, like I said, we are covering a lot of things in this presentation, but it's really just to expose you to the different things that we can do, the different things that are available to us so that we can help our patients control pain without opioids. And if we look at complementary therapies, okay, that's the last part of this presentation today, is what is out there besides medication? What is out there besides the nerve blocks and the different things in our ERAS pathways? What's out there that we can also help our patients with? And if you think about, you know, everything that we've talked about the issues surrounding prescription opioids, and, you know, you look at all of the benefits of ERAS pathways, and there are consistent reports with those ERAS, when we follow those ERAS pathways, of reduced opioid consumption by our patients. And there's also other choices, though, that are available as well that are designed to complement the conventional treatment that we provide. And that's ultimately what we're going to finish up with today. And there are many options that are available to our patients. Everything that I've listed here and even more is available in AORN's guideline on complementary care. If you did not know we had a guideline on complementary care, I highly recommend you check it out. It's right in the front. So, but that's where I got a lot of information for what we're going to talk about today. But this is part of their guideline and some of the information from it. And ultimately, the big takeaway just from this slide is that we're focusing on reducing perioperative pain and anxiety by including holistic methods for optimizing the overall health and well-being of perioperative patients through the use of a variety of complementary care interventions that can be implemented throughout the perioperative care plan. Once again, it's not just something we're going to do in recovery, but it's something that we can implement pre, intra, and post, which is another way that we can really optimize our patients and make sure they have the best surgical experience. And let's see, I'm trying to like get y'all to lunch on time. So I'm like, okay, let's keep moving. Anyway, but when we look at the patient holistically and we're looking at the entire spectrum of their care, we can proactively address things like pain, anxiety, nausea, vomiting, even patient satisfaction. And we can tackle those things head on and oftentimes before the symptoms even begin. Now, there's a note on words, okay? It says complementary care. You will hear the other word alternative, okay? When we are talking about this in light of therapies being used in adjunct to our traditional surgical model, we're talking about complementary care. And so when complementary is defined by the National Institutes of Health as an adjunct to conventional medicine, whereas alternative is a replacement for conventional medicine. Now, you might see some treatments on both sides of the spectrum there that are the same thing, but what we're talking about are things that are going to be used in tandem with our traditional models. If you were in JD's presentation yesterday, he was talking about clinical aromatherapy as it's a complementary care therapy that we can provide. A lot of these help our patients have a reduced need for some of our more conventional treatment choices, like pain medicine, nausea medicine, and different things. So they're a great thing that we can add on to the care that we're providing. Now, we're going to talk about 3 because we don't have time to talk about all of them. If you want to dive into the guideline and look at more, you certainly can. But we're going to talk about music medicine, virtual reality, and clinical aromatherapy. And yes, I said music medicine, not music therapy. And it's a little nuanced in that, but we are going to explain the difference in the words there. And for your information, music is addressed in the guideline in section 6, virtual reality is section 7, and aromatherapy is in section 9. But let's talk about music. I love music. Music's one of my favorite things ever. I think all of us are familiar with the term music therapy, but not many people have heard of the term music medicine. And I know that it seems like it's the same thing, but fundamentally, music therapy requires a licensed music therapist, whereas music medicine relies on prescriptive pre-recorded music that's implemented by other clinical professionals. So music medicine then, if you look at what music medicine is, it is therapeutic music that has been pre-prepared for patients suffering from, experiencing a wide variety of medical situations, and it's being used daily in pre-op, in post-op, during surgery. Maybe if a patient's having colonoscopy, maybe they're having a dental procedure, maybe they're in labor and delivery or dialysis or having some type of pain management. Music can be integrated in a lot of different areas. And the idea that it's therapeutic is important, okay? It's not just any music they want to listen to. The idea behind therapeutic music is that it has the tempo of the healthy resting heartbeat, as a simple texture, and one that easily engages what's called rhythmic entertainment. And rhythmic entertainment occurs when the pulse of the music synchronizes with the body's natural rhythms, such as breathing and heartbeat. And that's clinically important, of course, because if we have stable body rhythms during a procedure, you know, that's as important to the success of the surgery as anything else, right? So we want our patient to be steady and stable, and music can actually influence a lot of that. Ultimately, music will improve your patient satisfaction. It's been shown to reduce the need for medication pre, intra, and post-operatively. It's been shown to reduce pain and anxiety, but also what's really cool is it blocks out surgical noise, okay? Our surgeons like to listen to lots of different music. I did have one surgeon who liked to watch eagles' nests when we were in surgery, and that was weird. It was very odd. We had to log into YouTube so she could watch the eagles while she worked. It was odd. But most of our dogs say, you know, loud, driving, fast-paced music, right? That is not the tempo of the healthy resting heartbeat that the patient necessarily needs to hear. And even though they're asleep, everything's still landing on their ears, right? Their body's still hearing it, and their body will still respond, okay? So the OR sounds, if you know, the driving beat of Highway to Hell, maybe we don't want our patient to hear that, or whatever they might be listening to. Our patients still hear, they still respond. So when our patients have their own headphones and they have that rhythmic music, It's going to block out other sounds, it's going to block out other conversations. No matter if our patient is lightly sedated, doing a MAC procedure, or fully sedated, their body is still going to hear the music. It's still going to respond. And you're going to get a positive physiological response in heart rate, blood pressure, breathing, O2 sat level, which I think is incredible. I think all of us, oh, one more thing before I jump to that. The other good thing about this is music can help with post-surgical orientation. If your patient goes to sleep listening to music, and as they come out into emergence and they start waking up and they're listening to that music again, it helps orient them to where they are, what's going on. They're like, oh yeah, I went to sleep, I was listening to music. Hey, the surgery's done, I'm alive, I survived, now let me go home. And so like it helps orient them to back what's going on. We all know that anesthesia can make people incredibly disoriented, and music can help with a lot of that orientation. But also, music is powerful. I think that if you've ever listened to an orchestra or a concert or a hymn at church or some type of music and you felt yourself moved emotionally when you listened, you know that music has a power over us that sometimes we don't understand, but we can be moved by it. And it's not just our emotions. We will physically respond to music as well. And music is one of your very cost-effective ways to improve the surgical experience for our surgical patients. And music, along with the other two things that we're going to talk about here very quickly, is along with the other things we're going to talk about here is a nurse-led intervention. It is not something you need a prescription for. It is something that nurses can implement and start and go with. Okay. All right, so the next one is virtual reality. Virtual reality is included in the guideline as a stress diversion intervention, and implementing VR is really implementing a distraction technique. So rather than just say, hey, close your eyes and think about the beach, we give them the ability to immerse themselves at the beach by hearing the sounds and seeing the beach and all of the things that VR can do. I spoke with a nurse manager at UT Austin named Jessica Hovland, and these are pictures from her DMP project when she was implementing it. And she had the nurses trying it out and whatnot. But what they found with virtual reality is that it can help reduce anxiety. It can improve induction compliance, which is really cool. Okay, having induction compliance improvement, especially that research in children, induction compliance. It's a positive form of distraction. It increases patient satisfaction. And this quote over here, it talks about how pain is influenced by anxiety. Okay, when patients feel anxious during the surgical experience, the amount of pain they feel can increase. VR puts patients in a more relaxed emotional state because the modules help to ease their worries. It diverts their attention from the pain they might feel or are expecting to feel. And we all know if you're expecting something and you're anxious about what you might be experiencing, you're gonna be nervous, increased heart rate, all of those things that make us worried. You can also use VR as a great option for anticipatory guidance for your patients. The guideline actually mentions several studies of pediatric patients who were given varying levels of exposure to the OR before their procedure. And what they found was that by having these very immersive, very educational experiences, the patients reported feeling more prepared, had decreased anxiety, there was an increase in induction compliance, decreased negative post-operative behavior, and an increased overall satisfaction. So a lot of benefits to virtual reality. Now, this is going to have a little bit more expensive upfront costs because there's a technology here involved, but once you have it and you have it set up, you can use it for different options for your patients. And also, they also found that the nursing staff and the anesthesia staff really liked the virtual reality modules as well. And when they were stressed out, they would go use them and it would help them calm down. So, you know, any option you want to help your staff or patients, it was good. And then the last one that we're going to talk about is clinical aromatherapy. And we are at time, so I'm going to go very quickly and try to talk very quickly on this. But complementary approach you can find a lot more in section 9 of the guideline. And there's also a great study, I've got it here from the Journal of Pain and Relief. You can also find this study at the Eloquil desk if you want to go look over there. But it's the role of inhalation aromatherapy, lavender and peppermint in the management of perioperative pain and opioid consumption was done on total hip patients. And I really encourage you to look at that study and go read more about what the benefits of clinical aromatherapy and what they saw in those studies, plus some more that they have on their desk too. But what are we talking about in clinical aromatherapy? The National Library of Medicine says that clinical aromatherapy is a therapy that can be beneficial in the inpatient or outpatient setting for symptom management for pain, nausea, general well-being, anxiety, depression, stress, and insomnia. It's also beneficial for preoperative anxiety for oncology patients, palliative care, hospice, end-of-life care, a variety of uses, and Multiple studies have shown great patient benefit when incorporating clinical aromatherapy into the patient's care. If you were here for JD's presentation yesterday, you got all of that information on how well patients have benefited from, and staff have benefited from implementation of clinical aromatherapy. But how does it work, right? And he touched on that yesterday a little bit, but we take these essential oils and they're concentrated organic compounds that are derived from plants, trees, roots, herbs, maybe even some rinds of some citrus plants, right? And they're extracted, distilled, and they create these oils that we're familiar with. And you have this, what you have is a 100% pure, high-grade essential oil. And smelling that oil actually creates a physiological effect in your body. Like we talked about music having a physiological effect. The scents and the aromas that you smell also create a physiological effect in your body, okay? And it can trigger, sure, a psychological response, kind of like you talked about yesterday. You smell bread or you smell a rose and you remember your grandmother's rose garden, you have these good memories, right? But they also create that physiological response because the smell goes in through your olfactory senses into your limbic system, and you've got your neurons and chemical components that are going to start talking to each other, and your body will physically respond to that aroma. Like if it's lavender, it's going to be, hey, let's calm down. Let's bring it down a little bit. So that's how you get that physiological response, not just maybe an emotional response to an aroma. Now, we're all familiar with peppermint, right? We've all used peppermint time and time again in a case because it smells better than whatever the infection might be that's brewing in whatever joint we're dealing with, right? But it can also help. It's great stuff, but it helps patients who are feeling nauseated. Citrus oils can make patients feel happy, give them energy, make them feel uplifted. And another thing about clinical aromatherapy is that it can be incorporated the night before surgery. Nothing compares to a good night's sleep. You don't want your patient coming in exhausted from a lack of, a night with no sleep, full of anxiety and everything else. So you give it to the patient the night before. And then if you look at your ERAS protocols and looking holistically at the patient, you're giving them another option to address any preoperative anxiety and optimizing them for surgery because they had a good night's sleep. So clinical studies have shown that clinical aromatherapy can start working in as little as 30 minutes. And aromatherapy interventions can be combined with our other complementary care interventions to reduce pain, nausea severity, patient anxiety, stress, and increase patient satisfaction. And in this particular study that I was talking about, the use of lavender and peppermint was associated with a decrease of 26% in pain, 33% decrease in opioid consumption, and 78% decrease in postoperative nausea and vomiting. That's really cool. And it's another nurse-led intervention that is very affordable, that can be implemented alongside the other care that we're providing for our patients, which is another way that we can help avoid opioid use. And we are out of time, so I will just show you this and encourage you to go look it up. There is legislation that is going to be into effect January 1 of next year, and basically it's going to mandate that Medicare reimburse for qualified non-opioid options for outpatient surgical procedures. And typically what Medicare mandates, our other insurance companies follow as well. It was passed into law in 2022 and goes into effect this coming January. But things like that liposomal bupivacaine that I was talking about earlier, that's a very expensive drug, and patients don't always get access to it because it's not covered, or hospitals say it's expensive, we don't buy it. It's going to be covered under the No Pain Act. Other things will be covered that may not were before, so that lets patients have more access to more options for their pain, and then also requires follow-up and reporting so that other limitations and things will be overcome. So definitely a cool act, something that you should look into and just make sure you're aware of, because if you're in your facility, other things will now be covered that weren't covered before. So make sure that you know about this act and know what's going to be covered so you can implement other things for your patients. But finally, if we want to just wrap everything up, okay? The No Pain Act is definitely a step in the right direction. We also have decades of data that demonstrate that opioids are addictive. There's a high risk for abuse and addiction, and we have seen how our surgical patients, how exposing our surgical patients to opioids and the excessive prescribing practices led many patients down the path of substance abuse disorder. But we've also learned that there's a more holistic, proactive way to care for the entire patient as they move throughout the surgical experience. So from education and anticipatory guidance to patient-specific treatments, and by involving patients in their care, by giving them a choice to use other complementary care techniques, we are empowering them to advocate for themselves and to make the choices that they want for themselves in their treatment and in their pain management. So that is all that I have for you today. I know that was quick and drinking from a fire hydrant, but if you would like to get access access to those sources and see what I pulled it from, and also just learn more about it. I highly recommend that you grab that QR code and learn more.